Hi, my name is Anjali Malik. I'm a breast imaging radiologist in Washington, D.C., and I'm going to be talking to you about breast imaging radiology, breast cancer detection, and more. So I have no conflicts of interest to report. I'm a breast imaging radiologist at Washington Radiologist in DC, and I'm also part of the Medical Advisory Committee for Bright Pink, a national nonprofit that works to educate and empower young women and their providers on their breast and ovarian health. So we're going to be talking about breast cancer statistics, why we do screening for breast cancer, the tools of the trade that we use for breast cancer detection, and some of our diagnostic and high-risk screening tools. So breast cancer happens in about 1 in 8 women, which is 12%, over the course of their lifetime. In 2019, almost 270,000 new cases of invasive carcinoma were detected in men, over 2,500 in, or women rather, over 2,500 in men, and 48,000 cases of DCIS in women. So you're looking at over 300,000 cases of both invasive and ductal carcinoma in situ within women. So this is affecting a large swath of the population. Of course, in these COVID times, we've seen that other things can affect more, but this is something that is, when caught early, curable, and that is the whole goal of screening, and we'll be talking about that a little bit more. Also, we know that, in the years to come, as we go over this COVID pandemic timeframe where breast cancer screening wasn't performed, we'll see the effects of not doing proper and accessible screening, and this will have even more powerful and, of course, alarming numbers for us to see. So screening mammography, any screening test is something that's done on asymptomatic people. So screening mammography is performed on asymptomatic women before there are any signs and symptoms. And our recommendation, the American College of Radiology and the Society of Breast Imaging, is every year, starting at the age of 40, for average risk women. So those average risk are those 1 in 8 women who will get it over the course of their lifetime. We'll be talking a little bit later about who is high risk and what the recommendations for them are. And the every year at 40 has shown a 40% mortality reduction, and it saves the most lives. And in a couple of slides, we'll be seeing how those lives are saved for women at 40. There is a lot of controversy that has surrounded breast screening. The USPSTF made some very controversial recommendations and updates to their guidelines in the mid-2000s, and the American Cancer Society also made the guidelines that you can see below in 2015. Both groups did admit that they didn't take the latest technology into consideration when making those guidelines. So for some perspective, and we'll be talking about it later, they were using studies that had been done using 2D mammography. We now use 3D. They were studies that predominantly used analog film. We now use digital systems that have a lot more capabilities. And they were not using fellowship-trained breast specialists, which is something that I have specialized in for my career. There are a lot of us across the country and across the world, and the studies have shown that we do a better job at the detection of breast cancer. So I just want you to take that into consideration when you see the different guidelines. And in fact, recently the USPSTF did say they are going to meet again to update their guidelines, and they will take 3D mammography into consideration. So I would look out for some changes to this. But for now, know that the American College of Radiology and Society of Breast Imaging recommend annual mammography starting at the age of 40. So women who were diagnosed with breast cancer by age, you can see in both the bar graph as well as in this table that the numbers really start picking up around the 4th decade of life. And that is part of the rationale for why we start screening at 40 but not younger. We know in these younger ages for average risk women, the risk is greater than the benefit in the sense that they have denser tissue. Even though the radiation from mammography is completely safe and within FDA limits, that radiation that they would be receiving is just still not going to give us as much information. And so for screening purposes, for average risk women, we're just starting at 40. For women who are at higher risk, we might start at younger ages. And for women who have symptoms, we might start at younger ages. But for the screening purposes, it's annually at 40. And I think that these graphs show us why those numbers came into focus. And then when I talk about life years saved, if you think about the life years that you're going to save for a woman who is diagnosed with an invasive and potentially fatal breast cancer, but it's caught early in her 40s, you're saving many, many years of her life. And additionally, 1 in 6 breast cancers are diagnosed in women in their 4th decade of life. So again, that's a rationale for starting in the 40s and not later in the 50s, as some of these other guidelines have suggested. Another thing is that some of these guidelines recommend dropping off screening at a certain age or changing the interval once women get into that postmenopausal timeframe. And the fact that the average age for breast cancer is 62, in my opinion, as well as the American College of Radiology and Society of Breast Imaging, is just all the more reason to continue with annual mammography from the age of 40 until the general timeframe is until life expectancy is lower than 5 to 10 years. So as an example, if you have a really healthy, fit woman in her 80s who's still driving herself and exercising and has no other major comorbidities, there's no reason to stop screening on her, versus you could have a woman in her 70s who's on home oxygen, who might have had, might be in congestive heart failure, things like that. And that's when you want to say, well, would breast cancer potentially be a cause of death, or would it be one of these other comorbidities? And even still, that's not a reason to stop screening. And you certainly would never want to stop physical examination. But that's when you give yourself some pause and say, let's really do the calculus on this and decide if that's something that we want to keep doing. So this is also a graph looking at different ethnicity, which is something that's really important. Of course, the last year, from a social and political perspective, had a close lens on race, but we in the breast imaging community do as well, because we do know that there are significant healthcare disparities when it comes to outcomes, when it comes to age of diagnosis, when it comes to access to care. And Black women do have higher rates of mortality, and even at different socioeconomic levels, they are presenting at more advanced rates with more aggressive disease. So even if you remove any of the differing socioeconomic factors, we know that Black women are at higher risk for more aggressive and advanced disease. So it's something that we continue to study to evaluate how to eliminate those disparities and, be able to take better care of women across race and ethnicity. And it's one of the reasons why the American College of Radiology has finally said that we consider Black women to be at higher risk and, recommend different screening if they have other risk factors in addition to that. So as I've mentioned, but certainly we'll be focusing on early detection of breast cancer is key. So again, the goals of screening are tests that can be performed on a large portion of the population for a disease that when caught early is curable. And breast cancer and mammography certainly fit the bill for that. Mammography is something that can be done on a large portion of the population. It's easy to access, relatively speaking. It is quick, it's cheap. It can be performed by a large number of people. So it's, you have technologists who can easily be trained in it, and it has good sensitivity, specificity, positive predictive value. The screening statistics and epidemiology for mammography are good when it comes to the detection of breast cancer. And we'll be looking at some of the numbers, but when caught early, breast cancer can be survivable. So it's not just survivable, it doesn't just decrease mortality, but it actually decreases morbidity. So you can have less extensive surgery, less complications. For example, if you can avoid axillary node dissection, you can avoid lymphedema, you can have better cosmesis, which is important for women, and it's certainly something that we should be taking into consideration. And just overall better outcomes. So 98% of women who are diagnosed in the earliest stage of breast cancer earliest stages, so stages 0 through 2, versus 24% in stage 4 are able to survive the disease. And this is just another example of that. And in fact, the numbers have been updated to 20% for stage 4. So, we know that there are always continued advances in chemotherapy regimens, radiation regimens, et cetera. But at the end of the day, metastatic breast cancer is going to have worse outcomes, and the goal is always for early detection. So, you hear about the screening controversies, you hear women talking about callback examinations, and here are just some statistics that I want to show you for what screening mammography does over a population. So if 1,000 women get screening mammograms, about 125 of them will be called back. So the goal callback rate is below 10%, but we do know that depending on communities or baseline screening, it can be higher. So about 125 women will be called back for additional imaging. Out of that, 20 women will be recommended for a biopsy, and out of that, only 5 will go on to have cancer. Now, if you're one of those 5, it doesn't feel like it's only 5, but from an epidemiologic and screening perspective, that's a low number, and it does show that screening mammography can catch those women with suitable sensitivity, specificity, and positive predictive value. So what are the tools we use for mammography? Well, I referenced, or that we use rather for breast imaging. So mammography is low-dose X-ray, and as I said, it's inexpensive, widely available, and has good sensitivity and specificity. And we're not even using the basic mammography that had been originally invented. We're now using digital, we're using 3D, tomosynthesis. That is, instead of just taking 2 pictures of each breast, which has a lot of overlapping tissue and a lot of false positives, we now take an arc picture of the breast. It's kind of like if you want to, a poor version of CT, in the sense that it doesn't have the level of radiation, but it does have that more detailed view of the breast. So it eliminates overlapping tissue, decreases callback rate, improves cancer detection. It's good for dense breast tissue, which we'll be talking about, and it can help evaluate some of these other things. It does have a higher radiation dose than 2D mammography, but it's still within the FDA limits. So this is just a schematic of how tomosynthesis works. Again, it's that arc of tissue, and you can see in that schematic below that if there were things inside the breast, they can be more easily revealed by tomosynthesis. This is another example. So here we have a normal 2D mammogram, and here we have tomosynthesis slices where you're able to look at the breast slice by slice, level by level. So this is like, instead of looking at a book with a closed cover, you're kind of looking at a flip book of the breast and able, again, to look at level by level. So this is one example of a 3D mammogram only finding. So these are 2D mammographic views of the breast. You can see this woman has very dense breast tissue, which again, we'll be talking about later. And really everything looks the same. And if there were a breast cancer in here, you might not necessarily be able to detect it. But then here, if we're able to get this to play, which I'm not, sorry about that, but if you were able to get it to play, you'd see the breast slice by slice. And most specifically, you would see this area of concern in really good detail. So of course, this is just a coned in view of it, but on the 3D views, you would be able to see this mass here really well delineated by the tomosynthesis views, whereas on 2D views, it kind of blends in with the rest of the dense breast tissue. This is that mass on ultrasound. Of course, it did go on to be an invasive ductal carcinoma that, I can say we were really only able to detect with 3D tomosynthesis. Eventually, this would have been detected because the patient or her physician would have felt it, or there would have been other symptoms going along with it, or it would have grown to a size that would be extremely obvious even on 2D mammography. But 3D mammography allowed us to catch it sooner than it being palpable for the patient. So dense breast tissue, like I had mentioned, is when the the proportion of tissue is greater than that to that of fat. So density isn't like the color blue or the color white. It just is a proportion of fibroglandular tissue to fat, both of which are normal components of every single breast. So women who have fatty breasts, it's just the composition, it's just the way they are. Yes, obese women are more likely to have fatty breasts, but I've seen thin, slender women who do as well. It's just their composition. And same for dense breasts. So yes, it is more common in young reproductive aged women. It's more common in thin, slender women, but it can be seen in women who even have larger breasts or maybe a larger body habitus. So the reason that this is important is because fibroglandular tissue is white, fat is black, and cancer is white. And so as we saw in that last case, a cancer could be hiding anywhere in here. And on 2D mammography, it would certainly be obscured. On 3D mammography, it would hopefully be better revealed. So options for dense breasts, routine breast exam, which of course can be challenging. Ultrasound can be performed, and we'll go over some cases on that. There's also the 3D mammography, which is of course now more standard. And then based on risk, they could get additional imaging that can be used for high risk. So these are things like physiologic imaging, which means doing more than just taking pictures. And we'll be talking about that in just a moment. So defining risk. So we said that 1 in 8 women will develop breast cancer over the course of their lifetime, and that is approximately 12%. So high risk is considered greater than 20%. So a personal history of breast cancer, family history of premenopausal breast cancer, a gene mutation such as BRCA1, BRCA2, of course there are others, CHEK2, CK, etc. And a history of chest radiation, so for lymphoma. These are all examples of things that could push a woman into high risk category. And again, annual mammography and annual breast exam, and then annual physiologic imaging would be appropriate for them. So 3D ultrasound, I had mentioned, it's a good option for women who have dense breast tissue and also those who are of higher risk. And it is able to help us find 3 per 1,000 more breast cancers in women when used in concert with mammography. It does remove intraoperative variability. So when we do ultrasound by hand, you could miss things, or you could call areas, but this allows us to look at the breast as a whole. It does have false positives. It does increase callback. So it's something to warn patients of that, as with anything, it can be like Pandora's box. If you're one of those 3 per 1,000 women who has their breast cancer detected by it, you're going to see it as a really good option, but it is good to warn patients that there could be a lot of false positives. So 3D ultrasound only finding, this was back when we were using only 2D mammography. You can see these are heterogeneously dense breasts, and pretty much everything looks the same. But on 3D ultrasound, we found this abnormal, irregular margin hypoechoic solid mass, and this did go on to be a breast cancer. So functional or physiologic imaging of the breast. So instead of just mammography and ultrasound, which are just still static images of the breast, physiologic imaging is a little bit more dynamic in that it's looking at things at the cellular level. So patients are being injected with some kind of substance that's taken in and based on cell permeability and other cellular level activities. Areas of increased activity take up these things that are injected. So whether it's a gadolinium contrast, whether it's a molecular imaging target, they can be used to identify areas of increased activity. The theory being that cancer is active. Of course, we know that other things are active and that these can also have false positives. They're good for women of high risk, women who have dense breast tissue and are also at elevated risk. They're good for surveillance, for example, for women who have had a personal history of breast cancer. And of course, they're used for preoperative evaluation for extent of disease and staging. So MRI, we talked about why to use it. It is the physiologic imaging. It's very sensitive for breast cancer, greater than 95%. And in fact, screening breast mammography or breast MRI rather, can allow for better detection of breast cancer, up to 15 per 1,000 in comparison to just screening mammography. But it doesn't use any radiation, so there's no need to worry about it when it's performed on women, for example, who are in their 20s and 30s. And it's good for the evaluation of implants. Reasons not to use it: it's expensive. The gadolinium contrast can't be used for people with known renal disease. There's been talk of it implanting in the brainstem, but if you're using certain agents, that's of less risk. It does require robust hardware. It can take time. There is fast breast MRI now that can be used for screening, and it's a shorter amount of time in the magnet, but it still takes time to do the questionnaires, put the IVs in the patients, et cetera. And so something to be mindful of. And then size restrictions, claustrophobia, and the fact that there are false positives are things to be aware of. Contrast-enhanced spectral mammography is another physiologic imaging option. It is basically tomosynthesis going along with kind of CT. You're using contrast similar to how you would for a CT, and you're able to use that to be taken up into areas of increased activity. It is a very quick exam in comparison. It's a much lower cost. You don't have to worry about the claustrophobia. If the patient's able to tolerate a normal mammogram, they're able to tolerate CESM. There are no size restrictions. But of course, it does use iodinated contrast, so it's still not available to those people who have renal disease, and it does use radiation, so might not be a great screening option for your younger reproductive aged women. So this is an example of CESM. This patient had a region of palpable concern. That's what this sticker is here. She has heterogeneously dense breast tissue. She's actually postmenopausal. This woman was in her 70s. So you can see that dense breast tissue doesn't always happen in only young women. It can be seen in postmenopausal women. This is the MLO view of the breast. And on CESM, after her region of palpable concern was diagnosed to be a breast cancer, she came in for a CESM. So you see here was the area that she was feeling. It was diagnosed to be a breast cancer, and that's what it looks like. And you'd almost think this is a mirror image because she has a matching area of increased activity in the opposite breast. And that went on to be a cancer as well. So she had almost matching cancers in both breasts. And you know, if you think back to those 2D images, you would not have been able to detect that mammographically. So this was the known breast cancer. This is the one that was detected by CESM. And again, great option for older women who might not tolerate an MRI based on physical limitations, you know, with it being face down, with them feeling claustrophobic, with them even being able to get on the table, for example. This is a great alternative. BSGI, or breast-specific gamma imaging. So this is molecular imaging based on radioactive tracer. It does have associated radiation, but it doesn't have that limitation for renal disease, nor size restrictions or claustrophobia. So this is an example of BSGI, or this is a case rather that we used for BSGI. So here's a woman with heterogeneously dense breasts. She's a high-risk patient, and on mammography, you don't really see a whole lot. On the BSGI, you see this image that lights up like a light bulb. So you can see the dark spot here. It did go on to be a breast cancer, and you can also see that she has abnormal lymph nodes on that side, which you could see on the mammogram. You know, of course, without comparison and priors, it would be tough to know if those were abnormal or not, but you can see that both the mass and the lymph nodes take up the radio tracer. So that did go on to be a breast cancer, and shows that BSGI is a good option for screening as well as extent of disease. So I hope this was a helpful talk going over why we do screening for breast cancer, why mammography and other screening options should start at the age of 40 in average risk women or higher, or earlier in those of higher risk. and why we do physiologic imaging in women of high risk or known cancer. If you have any questions, you can find me on Twitter, Instagram, or TikTok at Anjali Malik MD, or you can check out my website, anjalimalikmd.com. Thank you.